Hey guys, today I'll be discussing on the anatomy of the inguinal canal in relation to chapter 37 of the 11th edition of Schwartz, titled Inguinal Hernias. So just a quick introduction. 75% of abdominal hernias occur in the groin. Of all inguinal repairs, 90% are performed in men. The lifetime risk of inguinal hernias are as follows: 27% in males and 3% in women. In men, the incidence demonstrates a bimodal distribution, with peaks before the first year of age and after 40 years of age. In addition, 70% of femoral repairs are performed in women. However, indirect inguinal hernia remains as the most common type of groin hernia in both sexes. So here we have the right half of the pelvic bone. We have the anterior superior iliac spine on the upper left, and on the bottom right, we have the pubic symphysis, we have the superior and inferior pubic rami, the pubic tubercle, as well as the obturator foramen. So the first structure to take note of is the inguinal ligament, also known as Popart's ligament. This stretches from the ascis to the pubic tubercle and forms the floor of the inguinal canal. It's also the free edge of the external oblique muscles, which aren't going to be included in the illustrations as it obstructs the view of the underlying structures. At the pubic tubercle, some fibers of the inguinal ligament reflect laterally. This is called the lacunar ligament, or the ligament of Gimbernat, and resembles a triangular fan. And some more of these fibers extend further laterally onto the pectineal line. This pectineal ligament, also known as the Cooper's ligament, is fused to the periosteum of the pubic tubercle. And there is one more ligament of interest, but we'll get to that later. So like I said earlier, I didn't illustrate the external oblique muscles or its aponeurosis, but we need to take into account a very important hiatus or defect in the external oblique aponeurosis found superolateral to the pubic tubercle. This is known as the superficial or the external inguinal ring. The SIR is thickened laterally and medially by the lateral and medial crura, and these help to reinforce the rings and to prevent them from splitting or tearing. So, if we have a superficial ring, we also have a deep or internal inguinal ring, located about halfway along the inguinal ligament, and it is a hiatus of the transversalis fascia. So here we have, running from the deep inguinal ring to the superficial inguinal ring, the inguinal canal, which is a 4 to 6 centimeter long cone-shaped region situated in the anterior portion of the pelvic basin. It's a passageway running obliquely through the anterior abdominal wall. So within the canal traverses the spermatic cord in men, or the round ligament of the uterus in women, and they pass through the deep and superficial rings to reach the testes in males, or to the labia majora in females. The spermatic cord contains 3 arteries, 3 veins, 2 nerves, the pampiniform venous plexus, and the vas deferens, and it's enveloped in 3 layers of spermatic fascia. The diagram on the left is a summary of all the cord structures, and the diagram on the right is a summary of its different layers and its derivations in the anterior abdominal wall. And now we'll talk about the boundaries of the inguinal canal. As stated earlier, the external oblique muscle and aponeurosis forms the anterior border. The interior oblique muscle comes from the lateral half of the inguinal ligament, and its fibers run forwards and upwards, as opposed to the forwards and downwards orientation of the external obliques. A portion of it forms the anterior wall of the inguinal canal. Most of the fibers will run towards the midline to form the rectus sheath, but these lower fibers actually curve over the inguinal canal to help form its roof. So they run over the canal to its posterior and connects to the pubic tubercle. Deep to the internal obliques are the transversus abdominis muscles. They also originate from the inguinal ligament, but now stretch along the lateral third. Most of these fibers also go to the midline to help form the rectus sheath, but some of these fibers also curve posteriorly over the inguinal canal, forming a part of its roof and traveling behind the canal to also meet the pubic tubercle. Therefore, now we can finally appreciate the conjoined tendon, or the fusion of the internal oblique fibers and the transversus abdominis aponeurosis at the pubic tubercle, directly posterior to the superficial inguinal ring. In summary, these are the anatomic borders of the inguinal canal. Inguinal hernias are generally classified as direct, indirect, or femoral based upon the site of herniation. Important anatomic landmarks include the rectus abdominis muscle medially, the inguinal ligament inferiorly, and the inferior epigastric artery superolaterally. This vessel supplies the rectus abdominis muscles, and it's derived from the external iliac artery, and it anastomoses with the superior epigastric artery, a continuation of the internal thoracic artery. The epigastric veins course parallel to the arteries within the rectus sheath, posterior to the rectus muscles. These three structures make up the Hesselbach's triangle, where direct inguinal hernias arise from. Indirect hernias protrude lateral to the inferior epigastric vessels through the deep inguinal ring, while direct hernias protrude medial to the inferior epigastric vessels within Hesselbach's triangle. This illustration at the bottom is another way of differentiating the two types. These two circles represent the deep and superficial rings. Beside we have the inferior epigastric arteries and the Hesselbach's triangle, all of which correspond to the diagram on the right. Both types herniate through the superficial ring, but originate from different locations. Upon physical exam, during the inguinal occlusion test, differentiation may be possible, but this will be further discussed later. So direct hernias, which is usually brought about by brute force, only need to break through two layers of the anterior abdominal wall, namely the peritoneum and the external oblique. Indirect hernias, on the other hand, have to protrude through three such layers, namely the transversus abdominis, internal oblique, and the external oblique, taking into account all the aforementioned anatomic defects. Femoral hernias protrude through the small and inflexible femoral ring. The borders of the femoral ring include the iliopubic tract, the inguinal ligament anteriorly, Cooper's ligament posteriorly, the lacunar ligament medially, and the femoral vein laterally. So this table details the Nyhu's classification system, and it categorizes hernia defects by location, size, and type. It is comprised of 4 types, and type 3 is further subdivided into types 3A, 3B, and 3C. Direct hernias are classified as type 3A, regardless of its size. Femoral hernias are classified as type 3C, and recurrent hernias are classified as type 4. Type 4 hernia can be further modified with letters A through D, which correspond to indirect, direct, femoral, and mixed hernias respectively. So now we move on to the intraperitoneal points of reference, of which there are 4, namely 5 peritoneal folds, the bladder, inferior epigastric vessels, and the psoas muscle. The 5 folds are detailed in the illustration below, as well as their significance. In addition, 2 potential spaces exist within the preperitoneum. Between the peritoneum and the posterior lamina of the transversalis fascia is Bogros's preperitoneal space. This area contains preperitoneal fat and areolar tissue. The most medial aspect of the preperitoneal space, that which lies superior to the bladder, is known as the space of Retzius. The posterior perspective also allows visualization of the myopectineal orifice of Fauchard, a relatively weak portion of the abdominal wall that is divided by the inguinal ligament. And lastly, we have the vascular space, which is situated between the posterior and anterior laminae of the transversalis fascia, and it houses the inferior epigastric vessels. And that concludes part 1 of the lecture. Thanks for listening.